At the Marsden, at our single institution, academic cancer centre, we sequenced consecutive patients with newly diagnosed metastatic non-small cell lung cancer with circulating tumour DNA using the Guardant360 platform, as well as using traditional biomarker sequencing on tissue. And what we were looking for is whether or not we were able to identify more actionable variants with using the combination of ctDNA and tissue sequencing, which we detected. So there was a significant increase. So we detected, I think, about 30% extra tier 1 actionable variants by using this approach rather than using tissue alone. The other really important finding from this study was that we found that the time to getting biomarker results was faster using ctDNA, and the time to treatment was half in patients that we were able to use ctDNA to detect an actionable variant. And certainly we know that with tissue sequencing there are a number of issues and challenges. Certainly with sequential tissue sequencing, that can take time, but also you need tissue, and in lung cancer patients it can be difficult to have adequate tissue for complete molecular sequencing. The other difficulty is the heterogeneity of lung cancer and the fact that you can get false negatives. And one of the issues with that is now with improving targeted therapies, especially rare mutations that we can now target, the need for NGS and comprehensive NGS is urgent, and certainly using a combined approach may be able to lower the rates of false negatives. One other strategy that we propose, obviously using a combined approach can be financially expensive, is whether or not we start with a ctDNA approach and then think about tissue molecular sequencing in patients where we don't find a targetable variant is another potential approach to think about. And certainly I know there's been recent ESMO as well as IASLC guidelines regarding using liquid biopsies to try and improve our detection of targetable oncogenic driven lung cancers.